impacts normal daily life. But by and large, there's nothing wrong with this per se. I really like this cartoon because it illustrates this concept of psychopathology. So here we're at Wonderland Psychiatric Clinic, and little Bo Peep has lost her sheep. And the receptionist says, "She lost her sheep again?" Well, of course, she has a classic case of lamnesia. One of the criticisms of our own healthcare culture is this pathologizing normal or variations of normal. Sometimes we can intervene, but that doesn't mean that we need to diagnose it as a true problem. It imparts the message to people that there's something wrong and that they're sick, which doesn't work very well with this particular population. We want to educate our patients to what's normal age-related changes and work with them and to keep their level of functioning. Well, among all the chronic conditions that exacerbate normal age-related changes in sleep architecture certainly are significant medical problems such as hypertension, heart disease, depression, etc. Common things being common, this is the slurry of chronic diseases that exacerbate normal age-related changes. Very often what you'll see with those patients with hypertension, diabetes, and heart disease are patients who have sleep-disordered breathing or obstructive sleep apnea. Depression, as I mentioned, is associated with a specific kind of insomnia, classically early morning awakenings. Hypertension, arthritis, depression, and diabetes are associated with restless leg syndrome, for example, or other sleep-related movement disorders causing intermittent awakenings. Another chronic condition is, I call it a chronic condition, I think it warrants the label of a chronic condition, and that's the idea of polypharmacy. This pile-on effect of numerous medications that cause sleep disturbances. So if you look at all of these classes of drugs, respiratory medications, etc., these often contribute to sleep disturbances. Also, what's not listed here, many of our elder patients take, are cholesterol-lowering medications such as statins that contribute to sleep disturbances as well. And then, of course, you're faced with, as a clinician, as a nurse or a nurse practitioner, you're faced with treating patients who have a progressive illness such as Parkinson's disease. What do? We give those individuals dopamine agonists. What does that do? Well, it reduces their bradykinesia, it reduces their rigidity, and makes them more physically comfortable. But guess what the dopamine does to their sleep? It worsens their sleep and often causes psychotic signs and symptoms that previously were not there. So these are individuals who will suddenly start hallucinating, seeing things that are not there, and they were not doing that before. So we get into this conundrum. We'll treat a chronic condition, one aspect of it, and then we create a whole new set of problems. Another chronic condition, and this is my world and the practice that I work in, and that is individuals in long-term care. Those of you who are here and you have loved ones who have a dementia process, we could give you an entire conference just caring for the caregiver. Suffice it to say, the take-home point here for caregivers of those loved ones is the following. The quality of a caregiver's sleep directly relates to the degree of cognitive impairment and nighttime activity of the person being cared for. This is one of the most pivotal issues that causes families to make the decision to place a loved one in long-term care because the caregiver isn't sleeping. Whether the person with a dementia process is in the community or in long-term care, this is what happens to sleep. It worsens. The dementia process actually increases stage 1, which is the very lighter stage of sleep. There's more non-REM, less slow wave. Why is that significant? It's slow wave sleep, deep delta waves that make you feel restored and refreshed the next day. As the dementia progresses, this condition worsens. And I was fortunate to attend a conference in San Diego earlier this year, the West Coast Psychiatric Conference. Geriatric Psychiatry Conference, and I heard one of my favorite authors speak about this very point, and she made the following comment. As the dementia progresses and the individual is transitioned to long-term care, she said the following: not a single hour is spent either fully awake or fully asleep. Not a single hour. So people are in this twilight haze 24 hours a day. And I heard that, and I read her original work, and I was so disturbed by that, I had to read it several times. We can do better. We have the knowledge to do better than that. We have the technology to do better than that, and we have the will. And we can do better. And I'll talk to you about some interventions on that. We know that sleep among elders in long-term care is hugely fragmented. It's disturbed. And it often results in what we call dream enactment. Dream enactment is violent behaviors. It can be sexual assaults, sleep eating, sleep driving if they're in the community. So this is something that we need to address, and we can address better and more safely. The other issue is, well, let's treat the dementia. Won't that make things better? Well, yes and no. So here again, the dementia medications, donepezil, which is Aricept, for example, causes nightmares, a further reduction in slow wave sleep. All of the dementia medications cause some disturbance in sleep as well. Well, we might be able to hold off or plateau the dementia, slow the progression, but these medications cause sleep disturbances significantly. Another chronic condition, again, is loss of function. What's happening is, as we lose our physical abilities, and the terminology is mobility disability. These are individuals who cannot climb one flight of stairs, for example, or walk without assistance, or are unable to walk 1/4 of a mile, have what we call a mobility disability. So what happens is this person becomes confined. They're indoors, and they're getting 700 lux of light a day. They're eating when they should be sleeping, and the converse. And so it becomes a vicious cycle. So to add to that clinical presentation of normal age-related sleep changes in light of chronic conditions such as dementia, loss of function, polypharmacy, I want to talk to you briefly about some of the primary sleep disorders that can occur and do occur, slightly more prevalent, more incidence of these in the elder population. Well, the sleep disordered breathing or obstructive sleep apnea is one of those disorders that actually you would, as a nurse or a nurse practitioner, want to refer to a sleep lab. These are individuals who do need a polysom to rule this in or rule it out. So these are the individuals who, because of the disorder, are having cessation of respirations during the course of the night, or partial cessation of respirations, resulting in repeated arousals, wakefulness, resulting in snoring and excessive daytime sleepiness. So these are the individuals that if you talk to the family, what do they say? Oh my gosh, his snoring, you know, it just reverberates against the walls. So that's almost diagnostic when you start hearing things like reverberation in the walls and snoring to beat the house down. That's almost diagnostic of OSA. The treatment certainly is the positive airway pressure. That does work very well if people will comply with it. Approximately 30% of those aged 65 or older have OSA, and many of those are not properly diagnosed or referred for proper diagnosis. Restless leg syndrome. Well, this is one of my favorite things to talk about because there's a lot of things that look like restless legs that are not restless legs. And then, of course, the treatment for them, my favorite, the dopamine agonists, can worsen other aspects of the clinical picture. So these are the people who wake up in the middle of the night with the creepy crawly sensation in their legs. They're rubbing their legs. They get up, they walk around, then they go back to bed, go to sleep, then they wake up again, and this is a vicious cycle. So these individuals never get into the deeper stages of sleep because they're not asleep long enough. The FDA-approved medications, of course, is Requip or ropinirole, and again, that's a dopamine agonist. So many of my patients who have a dementia process, many of them have restless legs. What do you think this medication will do to their dementia? It will worsen the clinical picture. So we have to address these problems in other ways. About 10% of those age 65 or older have restless leg. Periodic limb movements, treated the same way with the dopamine agonists. Here, this is the cluster of repeated leg jerks. This is the one that's diagnosed really by the bed partner. You know, he's kicking me all night long. And that's almost a positive for periodic limb movement. Many of the medications, treatments for depression actually exacerbate restless leg syndrome and periodic limb movement disorders. So here again, and this cannot be overstated, and it'll come in on a later slide, we've got to do a very good, thorough medication review and look at what could be exacerbating, if not causing, these kinds of problems. Now, this is becoming one of my favorite topics because we are actually causing this problem if it's an acute exacerbation or an acute event, acute onset, and that's the REM behavioral disorder. Now, these are the people who are sleep driving, sleep eating, sleep sexual assaults and violence, and their dream enactments. Now, this can happen, as I mentioned, as the dementia progresses. People who are on the newer class of drugs called the non-benzodiazepines have been known to cause these particular kinds of problems. So if this is reported to you, you want to again do a good medication review. The non-benzodiazepine class of drugs, and I have a slide on that here in just a moment that will list them for you. This is a good place to start to look. Could this be the problem? Especially if it's a sudden acute onset. Tricyclic antidepressants, some of the SSRIs, specifically fluoxetine, which is Prozac, and the monoamine oxidase inhibitors can all be culprits in causing this particular problem. So we have to remove the offending agents. If it's a chronic problem, this has been going on for a long, long time and a medication review has been done, then you're looking at more of a neurodegenerative process such as a Parkinson's disease or a Lewy body dementia. The first step, if we revisit all of these things we've talked about, is a good history and physical exam, and a sleep assessment is absolutely critical. Laboratory work is very important as well. Baseline labs such as a CBC, looking for anemias. Iron deficiency anemia can be a culprit and can cause a wide variety of lower extremity movements, thrashing around in bed at night, and so forth. Checking a thyroid panel, hypothyroidism, hyperthyroidism contribute to the obvious sleep problems. Checking an oxygen saturation, if it's low, possibly an OSA, sleep disordered breathing. Also, what's not on here and should be is an A1C. Diabetes is known to cause intermittent awakenings. Why? What do diabetics get? Where do they hurt? In their feet and their legs. They wake up, they're rubbing their legs, they walk around, then they go back to bed. A mental status exam is important to assess mood. You want to assess mood, attention span. You're looking for depression. Again, the medication review is essential. And then, of course, the sleep history. There's all kinds of sleep history questions. Let me just give you a few. Do you nap during the day? How long and on the average? Are your sheets and blankets in extreme disarray in the morning when you wake up? How often do you wake up during the night? These are the typical kinds of sleep questions. It tells you a lot about their overall health. The Epworth Sleepiness Scale, the Pittsburgh Scale, these are all available to you, these particular assessments. I've given you a link so you can download these and start including them in your practice. We have to ascertain normal age-related changes in sleep architecture. That's the purpose of this slide. We have to ascertain the presence of chronic conditions that are exacerbating factors. And then we have to look and consider if they're true primary sleep disorders.